in 2011. We have beginning to develop stronger relationships with post-acute providers in the marketplace with our long-term acute care, inpatient rehab, and home health and skilled nursing, and we put some good deal of effort into that. We have a history, obviously, since we've had PHOs and have been taking capitation in the risk business for 15 plus years. So we do have experience with actuaries and reinsurers, but we've been assessing our capabilities in those areas, spending time with our actuarial partners, and which includes our friends from Melbourne, and also our reinsurer, and identifying reinsurance opportunities on a go-forward basis. Last but not least, we have really engaged with our payers, including CMS, direct with CMS, but we spent a lot of time with Anthem, United, and Blue Cross of Illinois in terms of talking about outlining future contractual relationships. So that's been a key component of our assessment in 2010. In the middle of the year, 2010, we joined the Brookings Dartmouth ACO Learning Network, and for the health systems out there that aren't familiar with that, I would encourage you to look into that opportunity from a learning and ACO development perspective. As we move into 2011, and really starting with the elections in November, naturally there was the discussion. The November elections generated the discussion of, well, should we continue down the path of developing our accountable care organization, given the uncertainty of the current health care reform law? The answer has been a resounding yes from our senior leadership to our board of directors, in as much as the principles of the accountable care organizations, the preamble that Dr. Berwick and others have set out for us, better health, better quality, lower cost, are clearly aligned with the vision of Franciscan Alliance, and so we have continued down the path. We've also had a number of discussions with rating agencies, and expect that as rating agencies look at the health systems that they monitor, the development and where health systems are at in their development of accountable care organizations will be top of mind in the 2011 rating agency discussions. And finally, if you believe that, as Franciscan Alliance leadership does, that we really have a serious cost problem, that we've, to some degree, effectively priced ourselves out of business, we know that systems of providers must work better together to improve the quality experience, the patient experience, and work diligently to reduce the cost of health care. As we move into 2011, a lot of our attention turns to physician leadership development and really engaging our physician leadership in coming together with management and developing chronic disease programs, working within the hospital to improve throughput, cost, efficiency, reduce infection rates. So it has become a major focus, probably the top focus for our organization as we move into 2011, to really engage our physician leaderships and expand our physician leadership in that arena. We continue to dialogue with our major payers. We are beginning to have serious discussions now about changing the economic model, perhaps as early as 1/1/12, to really have contracts with all of our payers that, as Governor Doyle suggested, move us into a highly incentivized to improve quality, reduce variation, drive out unnecessary utilization. So those, right now, our goal is to really be ready to go live with contracts in 2012, and but I can't overemphasize the effort that our organization is putting forward, and really the list of leadership, management, and positions each month that is involved in our ACO development expands each month, and has become the top priority for Franciscan Alliance in 2011. I'm now going to turn the program over to Warren for his comments.
Thanks, Jay. Next slide, please. Well, the story that Jay has just shared with you with regards to Franciscan Alliance and their journey towards accountable care is certainly atypical. And I say atypical because I think Franciscan Alliance has taken a very proactive approach, a very strategic approach, and in many ways started many years ago. And I think as we tell the story, and I'll talk a little bit about, thinking about the CMS proposal, for example, you will see that a lot of the infrastructure, a lot of the strategic investment in, aligning with physicians, having Advantage as a partner with them in that, and having the experience and the credibility of taking risk on patients in a capitated type model is something that most health systems in this country don't have. To Jay's point earlier again, certainly there are those that are significantly out front, those that we hear of in the industry media significantly, the guys in here, the advocates, the Kaisers of the world. That next group is a fairly small group that I think Franciscan Alliance fits. However, our experience is that very quickly most healthcare systems need to very quickly start moving in the direction of how do they participate strategically, how can they align themselves and think of all of the things that they need to assemble to become an accountable care organization. A couple of things I think bear mentioning, and I'm sure came up to some degree in the last webinar, and that specifically is that, number one, the ACO regs are not out yet. Our understanding is they are under executive review right now within CMS and government agencies. I think the new timeline, as we've heard recently in our meetings in D.C., have been in a February timeline. We would anticipate the draft regs for ACOs to be available. At the same time, when you look at PPACA and you look at the shared savings pilot program, I think it's worth noting and clarifying that this is not, specifically the ACOs, is not a demonstration project per se. It really is a pilot, and there is a significant difference. It's more than just semantics or nomenclature. This is really allows some flexibility, if you will. At the same time, it should be noted that there is not only a CMS shared savings pilot, if you will, another word for accountable care organization pilot, but that the Centers for Medicare and Medicaid Innovation, or CMMI, may be looking at innovative delivery and reimbursement model pilot programs as well. So there may be a couple of different avenues that ACOs, given the broad parameters that we anticipate in discussions that we've heard coming out of CMS, Dr. Berwick and others, that will allow for a fairly broad interpretation and parameters around that, such that the ACOs from a regulatory perspective, can meet those requirements and still be defined, if you will, at the local market level. So certainly there is broad opportunity there. But clearly I think there's a couple of things that you need to be considering, and not only that I know Jay and his team at Franciscan Alliance have thought about, but certainly others across the country, clients of ours or prospective clients with regards to their participation in an ACO. Just by way of backdrop, how do you know and how do you have the types of things critically in place that Franciscan Alliance has in order to have you in good standing and poise you well to have an ACO set up? And I think first and foremost, as the topic of this particular series is, aligned physicians' incentives that are absolutely paramount to your success. It builds not only trust with your physicians and your ability to work together, it clearly is the backdrop, it is the requirement in order for you to move forward. That may have occurred with different types of alignment models preceding ACO development, whether it's a PHO and a PHO type model with aligned performance incentives all around quality and efficiency, whether it's co-management companies, whether it's some sort of joint venture. Regardless, any way you look at it, having that history and that background of aligned incentives is a critical component in order for you to be able to move forward. If that hasn't happened, we certainly encourage, for lack of a better term, we call it gateway physician alignment models moving into that ACO if you don't have it. Clearly, physician leadership and an active role in governance is absolutely critical. In many ways, as this delivery model under an ACO moves forward, you are going to need a very collaborative approach and a very collaborative platform for you to have the types of discussions that you're going to have between all of your providers, but in particular hospitals and your physicians. In many ways, you will be redesigning not only existing protocols, but putting it through the pathway. So clearly, having the ability to understand the issues and have that platform for significant and real physician leadership in that role of governance of an ACO and decision-making on a day-to-day basis. And I would say that represents not only clinical operations, but I think some of those strategic decisions are absolutely critical to include those physicians as well. In particular, and kind of one of the reasons for this is certainly based on infrastructure. Concerns that we see and we face with many organizations with regards to developing and implementing an accountable care organization is the fundamental not understanding what is required to become an accountable care organization. There will be significant infrastructure required. For example, Jay mentioned employed physicians, but clearly in most markets it's going to be a number of different physician models, whether it's employed or some sort of relationship. But it also includes such things as home care, rehab care, post-acute care, continuing care facilities, and ultimately when you see moving to that population health management, perhaps moving into that front end of prevention and disease management as well. So clearly that represents new infrastructure that most healthcare organizations frankly do not currently have. So that's going to take a major reinvestment, and this particular issue will be explored in an upcoming section here, and I know Vicki Perry is going to talk about that at some length in terms of what type of infrastructure, what are you doing, and how that impacts the financial model for ACOs. The other thing that we do an assessment on to make sure that there is some sort of readiness, if you will, or readiness assessment for a healthcare organization to move into the ACO is the necessary understanding of the culture change required. One of the things that we clearly try to articulate both to executive leadership or administration in hospitals as well as physician leadership is this really is a transformation. In many ways, again, in contrast to the organizations, including Franciscan, most organizations are hospitals or hospital systems. And the transformation really comes down to, in a bottom line way, into moving into a healthcare organization. So that is moving outside of those silos that we've talked about that exist in this industry based on, in many ways, the reimbursement model that currently exists, that fee-for-service model. So clearly breaking that down and understanding that the transformation that must occur is that moving to that larger healthcare organization with all of those components, both pre- and post-acute care delivery. So, when we talk to administration, we say clearly your career is almost exclusively focused on both inpatient and outpatient care, almost exclusively, or at least at a 95% level in most instances, emanating from the four walls of that hospital. And the game is going to change under an accountable care organization. You are now going to be responsible for the entire healthcare delivery model, right from the front end on major prevention and wellness, all the way and disease management, all the way through the acute care and post-acute care phases. And this really represents a very new and very significant challenge, both from a management perspective, from a strategic perspective, and I think understanding that and first and foremost educating your board of directors on that is absolutely critically essential. So in many ways, having that front-end mature discussion, again, with your physicians, with your board of directors, with your executive team, for that culture change, recognizing what you're going to have to do first, everything from physician alignment, leadership, and a recognition of investment in that new infrastructure. This isn't a quick turn. Many of you have probably seen the YouTube video of a hospital CEO reaching out to a consultant to try to find and capture new reimbursement model and quickly becoming an ACO organization. We have to say that to do this and to make this successful requires very significant and critical understanding. So when you think about and you've made that commitment as a healthcare organization to move into the ACO and understand all of those components, have your blessing from your board of directors, and moving on to that CMS proposal. Again, first you must recognize the regs aren't out, so I know a lot of people are in the wait and see mode, and rightfully so. So there's just a lot of consideration at this point with regards to the CMS pilot. But for those that are getting ready and thinking about their proposal, whether it be to CMS or through the CMMI route, I think one of the key pieces of advice that we would be giving to clients would be to demonstrate success. Obviously, CMS is putting a lot of weight into this and a lot of energies to look at this as an alternative model that obviously increases quality, decreases the inefficiencies in the system, and represents, again, as Governor Doyle kicked us off with, an improvement, and really fits under that umbrella that we see in PPACA called value-based purchasing. This is really about increasing that quality cost equation and producing better value. So as CMS places a fairly significant bet on ACOs and tries to demonstrate its success through this pilot, they're going to very carefully look at in those proposals those that have the pieces of the puzzle, that are aware of the infrastructure needs requirements, the importance of physicians and their physician alignment, that they have some history with this, some success factors in the past. It really is, for lack of a better term, a show me. You've got to demonstrate very clearly in that proposal that you understand this, that this isn't something you're just going to flip a switch and feel as though you're going to make just very small incremental changes to your current delivery model and reimbursement model and expect significant differences. This really, again, is a transformation, and I think they're going to be looking for all of those components. And through that, more specifically drilling down, is in that transformation, understanding and translating all of the things that are going to come in through the regulatory requirements that we're going to see a draft form here probably in the next 4 to 6 weeks. But again, remember, they're going to go back for after the comment period that CMS will have. We're probably not looking at final regs now for several months out, is interpreting that back and applying it back to those operational challenges. So doing a gap analysis, if you will, in terms of what are the infrastructure needs that you're going to have to be a successful ACO, what do you currently have, and frankly, how do you plan to transition through that gap analysis of acquiring, building organically, some of that infrastructure. How is that going to happen? Laying out that plan operationally and tying that together in order to be successful. So I don't think there's an expectation from CMS that everybody have all of that infrastructure in place, whether it be physician or post-acute care or disease management, but certainly that there is a very clear plan. So again, the plan has to start from the strategic in a very mature way, show that transformational nature that's going to be required, showing that over time, and clearly CMS's expectation is, and certainly in order for this to be successful, you're looking at a 3-year commitment. So this isn't something you're going to get up and running in the first quarter of implementation, and it's certainly not expected that you would have all of that going, and a mature understanding that there's going to be some year 2 and some year 3, and it takes a while for some of those results. And certainly from the financial side, I'm sure Melvin's going to talk about that too, you're not going to realize that until subsequent years, even if you do set that up in first year. So understanding that long-term commitment, if you will, in many ways is critical. I think one of the things that certainly we bring up very quickly in our discussions with clients, and I think those that are mature to enough in their evolution down this population health management / ACO role, is that there is an inherent conflict between the fee-for-service model and ultimately to more mature stages of the ACO model. Certainly Jay got that and understood that a long time ago, and is very atypical of a lot of CFOs, and understanding that inherent conflict that in order to be successful in the fee-for-service model means that you probably won't be successful in the ACO model. Specifically, some of the interventions, and you'll see again in the upcoming section, that are going to occur very quickly, that low-hanging fruit in terms of those interventions as an ACO, are reduced ED admissions or visits. Again, a significant intake valve for most hospitals. And obviously, if you're trying to limit that, that probably isn't going to work well for your fee-for-service model. Obviously, when you look at, and even though under value-based purchasing in PPOC and starting in 2013, such things as readmission for heart failure, AMI, that 30-day readmission will not be reimbursed. Still, even how that methodology is laid out in PPOC, clearly one of the disease management, chronic care management strategies that I think most people recognize right away is around readmissions for heart failure patients, for pneumonia patients, for AMI patients. Again, in order to be successful as an ACO means really no success and is really counterintuitive to the fee-for-service model. So how are you going to reconcile that? And certainly in your financial modeling, you have to be aware of that. And again, this is all part of an investment and a recognition that success is going to really depend on that. So finally, what we say, and clearly CMS understands this and believes this too, is this should not be, as Jay said, just a hobby, that this indeed should be something is more than just a cottage industry, and that there is, again, commitment there. So not keeping it just a CMS-based initiative, and looking at this as a potential model and taking it to your commercial insurers and look at opportunities to work with them on an ACO model. Jay mentioned several commercial insurers, but there are so many regional ones that are quite interested in this model as well too. So obviously many of them are waiting for the regs as well too to see directionally where this is going. but I think it is in everybody's best interest if you look at beyond just the CMS Medicare pilot and start looking at those commercial insurers as well too. This may be at a state level. I know there are several states that are looking at developing a state collaborative, whether it's with Medicaid or other patients beyond that, but clearly looking beyond just the CMS pilot, because ultimately, again, to be part of this transformation, there has to be an understanding that this is going to permeate all aspects and all components of a new transformed healthcare organization, and that this cannot be a hobby in order to be success. That doesn't mean that you don't ratchet it up over time and that there is an incremental approach there in that transformation, but clearly understanding what finish looks like is going to be critical in order to be judged as successful by CMS and other payers out there.
Yeah, Warren, I'm not sure about the atypical comment. I think one of the most significant challenges that financial leaders and all leaders of health systems have in 2011 and 12, at least, is not knowing exactly what the economic model is going to look like or be. We're very challenged in planning our organizations, valuing current business opportunities, since we have the assumption that in a big way the fee-for-service payment model is going away, but we don't know exactly what that's transitioning to. So we're, Franciscan Alliance is equally challenged as all health systems are in making critical decisions in 2011.
Yeah, I think that's a great point, Jay. Certainly this is times of uncertainty, and clearly I think it's being proactive, and certainly Jay and Franciscan Alliance have been very proactive, again, in times of uncertainty to be prepared for that future. And I think everybody, to your point, is very much challenged by that. However, sitting back and being reactive may not be a good solution either. So kudos to you and your team for taking that type of approach.
Thank you. I do want to emphasize, too, we've tried to emphasize in our remarks the importance of engaging, identifying physician leadership. We for the most part, we know who they are in our respective organizations, but engaging them in the health reform and the ACO discussion, I was very apprehensive about that several months ago. We really started in earnest in October of last year in terms of reaching out and engaging physician groups, physician leaderships in health reform and ACO discussions. Frankly, I've been very encouraged with the response. I think that physician groups, just like hospital health systems, understand the flaws and the challenges that the current health system creates. And again, I've been very encouraged with the response and physicians stepping up and wanting to be more accountable and very interested in engaging with our health systems in moving the health reform and accountable care organization law forward.
All right, thank you. Thank you.
Thank you very much, Jay and Warren. We're now going to hear about financial risk models from John Mearshot and Keith Kiefer from Milliman, and I'm going to turn it over to Keith Kiefer in Milwaukee.
Good afternoon. As Fred mentioned, I'm Keith Kiefer. I'm presenting with John Mearshot. We're both consultants from the Milwaukee office of Milliman. I'm a former health system CFO, and most of my practice is working with integrated delivery systems on strategic or payment matters. John's an actuary who works with providers, payers, and a number of the Medicaid agencies across the country. First of all, we'd like to thank Foley for the opportunity to talk with you this afternoon. It's a great pleasure for us. As Fred mentioned, our topic is ACO reimbursement and risk models. I think as we move into this new era, or for some of us that have a little more gray hair, maybe back into an era that we may have been through before, it's our belief that it is just as important to get paid in the right fashion, use the right reimbursement structure, as it is to determine the amount that an ACO should be paid. Any given year, the amounts might be the same. However, the structure has a large impact on the organization's ability to move forward and be successful during changing times. You choose the appropriate structure for your ACO and be a tremendous asset towards achieving your strategic objectives. But if you choose the wrong structure, many times it can be a huge barrier towards achieving any sort of future success. Next slide, please. First, we'd like to just discuss some of the reimbursement structure factors that we think have an impact on an ACO's effectiveness towards achieving those goals. Then we'd also like to talk a little bit about some of the common reimbursement structures in use today, and also some of the other things that are starting to show up, maybe not commonly used, but we're starting to see those in some of the design work we're using or in other environments. Our comments are intended to be a little bit broader than just Medicare ACOs. So when we think about the ACO environment, we understand the regulations are coming out from a Medicare standpoint, but for the most part, we're thinking much more broadly. We think an ACO strategy is really an overall strategy for an organization, not something that's limited to a specific payer in most cases. And then we're primarily going to focus on the financial aspects of these different reimbursement models. We're not really going to touch on impact on quality or customer service or any of the other dynamics that may be in play. Next slide. There are many reasons to consider alternative reimbursement structures, sometimes by choice, sometimes not. But I think as we talk to a number of organizations, or as we stand back and think a little bit about sorts of things that you should be thinking about when you're evaluating different options, the first is trying to understand what might be happening with your future payment levels. I think there's particular concern about fee-for-service payment levels in the future, but having an understanding of what the future may look like in your market is an important aspect. Might make sense to change your reimbursement structure or evaluate alternatives just simply to get better alignment with what you've already accomplished as an organization or what you plan to accomplish. Different structures have different impacts. We know organizations are looking at different options to remove barriers to achieving some of their organization objectives. And as I mentioned, maybe the last thing to think about is it's maybe something you have to do, not necessarily by choice, but the market demands it. And you just really can't control that. But most important point about all of this is that I think it's important to pay attention to these factors under your circumstances and to make sure that you have a plan to position yourself favorably as your market changes. We believe most markets will change. The degree to which they change and the speed at which they change will differ, but you have to be a little bit ahead of that or you're going to find that your financial performance is going to suffer. Next slide, please. Some elements of a good ACO reimbursement risk model include providing financial stability for the organization. It almost goes without saying. We think that all the models, or a good model, also has a potential upside associated with it. So if you achieve your organization's objectives, you should have better financial performance under a good model. We also think that the models themselves should help position yourselves or your organization to grow your market share, or at least maintain your market share. And then lastly, but certainly not least important, we think that the structure itself should have a positive impact on your organizational performance. Next slide, please. And the way that it does that is by getting your incentives aligned internally in your organization. There are different ways to do that, but one good model that we see has a couple of common characteristics, or a couple of common characteristics in the models that we see are sharing risk for the utilization changes across all of the ACO participants, but keeping the responsibility for the unit cost management, controlling your own operating costs within the individual organizations. That sort of dynamic, in our experience, puts the focus on providing the right amount of care in the right place in a collaborative manner, but still allows operational autonomy. And that balance is something that you're seeking to try to move your organization in the right direction. It's not that you can't achieve it with other structures, but those two aspects seem to work best with the organizations that we work with. Next slide, please. When we talk about risk, usually in the context of ACOs, or when we talk about risk related to reimbursement, it conjures up the images of capitation. In some settings, those two seem to be synonymous. However, the context of what we're going to talk about today, when we talk about risk, we're really talking about potentially adverse circumstances, but also opportunity, an upside to it. And really, as we look at reimbursement structures, I mean, the common attribute of all reimbursement structures is that they all have the potential for serious adverse financial consequences, and they all have a substantial upside. And the difference is the circumstances under which they're applied. So to say that there's a best reimbursement structure for any organization or for ACOs in general is ignoring the fact that it's really the local circumstances that make the difference. So our point about this is really be objective about evaluating the risks and the opportunities related to any reimbursement structure you're considering. Don't just assume that there's a particular structure and it's right because you're in an ACO. It's much more complicated than that. We talk about some of the general considerations that you should have as you start to evaluate these reimbursement structures if you're in an ACO setting. And the first is most ACOs are coming together, or most organizations that are going to function as ACOs have really been moving varying paces, but towards an environment where they anticipate taking population-based payments. Seems maybe fairly obvious. The point that we'd like to make about this is to make sure that you are strategically moving in that direction with your payment structures. We see lots of operations coming together to facilitate that, but the reimbursement structure is lagging behind that. So really need to be able to get to make sure that you have a plan to move you at a reasonable pace towards better reimbursement structures and more appropriate population-based reimbursement structures over time. The speed at which you move and the degree at which you move across that spectrum will vary a lot based on the factors, the dynamics of your market, your competitive position, the maturity of your ACO, your organization's financial position, political issues within your organization, your structure, quality of your leadership, a whole host of factors. So we don't believe that any two organizations, even in the same market, are likely to move at the same pace. The common aspect of it we see as organizations move into a more ACO-type environment is that we believe that transition is going to be gradual rather than sudden like it was back in the 90s. We don't see many markets, many organizations who really plan to jump from a fee-for-service reimbursement into a capitated environment in a single step. Consequently, I think it's a reasonable expectation over the next several years, your organization is going to have a blend of reimbursement structures rather than a single plan. And you need to make sure that you're managing that portfolio and thinking about that as you move along your journey to a more integrated population payment-based organization. Next slide. We're a ways here. Let's see. How about if we jump to, I'm sorry, let's try. How about if we jump to slide 8, please? Thank you. So we move from maybe some more general comments about ACOs to some specific considerations when you're talking about an individual contracting situation. There are a lot of factors to consider. I don't think we're on the right slide here. Let me take, how about if we go, we get caught up here, if we go back one slide, please. Let's go to, I'm sorry, keep going forward. There we go. Nope, stop. Apologize for the confusion. not sure what's happening here. Why don't you go ahead one slide, please. Back. All right, go back a couple of slides then. Another one, please. There we go. All right, we'll work on with this one. What I started to talk about were some things that we'd like you to think about as you approach specific contracting opportunities. There's a wide range of factors. They all have a different impact on your particular situation, but it's important to understand where you're positioned within the market. Are your prices high or low? Is the utilization of your organization high or low? And what's the combination of those two things, and how does that position you from a total cost standpoint? What's the structure of your ACO? Do you provide a wide range of services that cover most of the needs of the payers, or are you a narrow ACO, a primary care ACO only? Is this a payer that constitutes a large portion of your business, or is this an organization that really represents a very minor piece of your business? Probably more important than anything else, what's your expected utilization trend? Do you believe that your utilization for your market is going to continue to rise, or is it leveling off, or is it dropping? What about your own organization in the aggregate, but also within the pieces of that? Having a good understanding of that is a critical element in terms of understanding what reimbursement structures might be best for you to help you have a stable financial position. It's important to understand where you think you're going to change. Are your opportunities for improving the cost or bending the cost curve a bit going to come from within your own organization? Or is it going to come from managing how you interact with other organizations? Or is it going to come from drug costs or other things that aren't necessarily provided directly by your organization? Next slide, please. And what's the size of this contract? What are the demographics of the patients and the members underneath it? What are the available reimbursement structures that the other payer is willing to enter into as you move forward? Which of those structures move you towards your strategic objectives, and which are those barriers that I mentioned earlier? How integrated is your ACO? And from that standpoint, I mean both from a clinical standpoint so that you can affect change, but also from a financial standpoint. Does the money need to be split up into a lot of pockets, or does it all go into one common pocket? Those things all have a substantial impact on how you design reimbursement structures to align the incentives within your organization as it's structured, but also to make sure that those funds are distributed equitably and that the pieces are working together rather than against each other to accomplish your objectives. Next slide, please. All right. Spend a minute or two here now shifting gears, and we'll give a brief overview of some of the more common reimbursement models that ACOs might consider. I'm going to handle, not being the actuary, I'm going to handle the more simple ones, and then John will come up here and talk us through capitation, hybrid models, and some of the other more complicated things that are starting to show up in the market. Fee-for-service reimbursement. I don't want to spend a lot of time talking about that. I think we all understand what it is. I think the primary thing to think about regarding fee-for-service reimbursement in an ACO environment is to understand what drives the risk around that particular payment. And probably the biggest thing that drives risk around fee-for-service reimbursement is utilization trends. And the reason utilization trends are important is that for the most part, the incremental change in payment is greater than the incremental change in cost when utilization changes. So in other words, if utilization goes up, providers get paid more than it costs them to provide that service. If utilization drops, payments for the providers go down more than their operating costs go down. So pretty strong incentive for providers to provide more. However, we're seeing that in a lot of markets as systems come together and become more integrated, whether they're integrated systems or ACOs or other organizations, that alone has a substantial impact on utilization. So as you evaluate fee-for-service reimbursement, even as a starting point, as the initial form of reimbursement for your organization, is very, very important to make sure that you understand where your utilization trends are, where you're managing them, and have a good idea of where they're going to go. Because being in this structure, in an environment where your utilization is dropping, it puts you in a cycle of trying to cost cutting to try to maintain your profitability that is very, very challenging and will distract from your efforts to try to integrate as organizations. So fee-for-service is good under some circumstances, but it's also got some risks as you get better at managing utilization. Next slide, please. Bundled fee-for-service reimbursement. There's a lot of publicity about this today. There are demonstration projects out there. I think most payers are dabbling in it. It's interesting, however, I think on whole we see it as something that generally has fairly limited applicability. It's hard to use on a widespread basis for the majority of services provided by an ACO. And when we talk about bundled reimbursement, we're talking about grouping together the services of a single organization around a single event, all the way through taking and grouping together the payment for multiple providers over an extended period of time. So perhaps the preoperative testing, surgery and rehab services for a particular, say, orthopedic procedure, including all the physician services, all the therapy services, all the hospital services. That would be a bundled payment, a fairly complicated bundled payment. The risks around, the places we see this particular form of reimbursement being used in the market, see payers trying to promote it as a means of dealing with a particular specific issue that they have. Could be an issue with your organization, could be an issue in the market, but somehow they anticipate they haven't been able to get their arms around it in another fashion, so they're trying to bundle the payment together to produce an efficiency or to produce a change in the market. Or conversely, we see providers using this as a mechanism to make I'll say a splash in the market, kind of tip the competitive advantage a little bit by assuming a little more risk around these types of services than they would normally do. Next slide, please. We look at the risks around this type of reimbursement structure from an ACO standpoint. They more or less look like the same risks related to traditional fee-for-service reimbursement. The biggest risk relates to the utilization changes of these types of services. If the number of bundles goes up or goes down, it looks just like fee-for-service reimbursement. There are some added risks or opportunities around this particular form of reimbursement. Obviously, there's a mix of services. There's a group of services that come together to form a bundle. If the providers are able to change that mix of services to a lower cost mix, there's an opportunity for some additional profit from that. But if the opposite happens, well, then obviously it's going to have a negative impact on utilization. And then the last thing to say about this, which is a very important aspect as you look forward at this, these things are administratively complicated. Now, some organizations already have a lot of infrastructure in place. The incremental costs can be small. But if you're an ACO that's forming, or an ACO that consists of many different organizations that aren't legally related, other than through the ACO, the administration of estimating the payments, negotiating specific payments, taking a bundled payment and distributing it, they can be very, very expensive. So if you have a small number of bundled payments, the fixed cost associated with that, it just may not be worth it. The juice may not be worth the squeeze. So it's something that we see activity in. However, you look as a long-term strategy for an ACO, it may not be a structure that really has a lot of legs, at least from our perspective. Doesn't mean you're not going to see it, but it doesn't seem to be an endpoint for us. Next slide, please. Next thing I would like to talk about are patient-centered medical homes, medical home payment structures. Generally, what we're talking about here is an additional payment to a medical group, probably mostly a primary care group, although it could be a specialty group, to provide the infrastructure and an incentive for the physicians to more aggressively manage patients with chronic illnesses. For the most part, the results of this type of a program are pretty impressive. I've seen some studies that suggest that the impact of utilization within this defined population, you can cut hospital utilization in half, some of the outpatient diagnostics by a third or more, and that there's a similar level of reduction of specialty physician payments as well. So substantial cost savings through this mechanism. Next slide, please. We think this structure makes sense and can be effective for a couple of types of ACOs, but ought to be used in caution with others. If you're a primary care physician ACO or a physician-only ACO that has strong primary care base to it, this might make sense. The impact, the incremental payments that you get will result in health plan savings, but not necessarily impact your overall level of profitability. If you're a capitated, multi-provider, large-scale, large-scope ACO, we think this is a great internal program to have as a means of trying to drive down utilization when you've assumed the risk for the cost. If you're talking about other providers or other structures, and you're in payment mechanisms, reimbursement structures other than capitation, probably is not, at least the examples we've seen probably don't make a lot of sense for you. You might get incremental payments to the primary care physicians, but you're likely to lose contribution margin on the reduced utilization of all your other services that far outweigh the benefits from the incremental payments. So, and we like this slide so much we included it twice. Next slide, please. And if you go to the slide following that, I'll let John talk to you a little bit about capitation.
Thank you, Keith, and thank all of you, both in person and on the phone. It's a pleasure to be with you today. Like Keith said, this is the time of the presentation where it gets thrown over to the actuary to talk about capitation. As most of you are aware, capitation arrangements, capitation payments are really payments based on the average cost of the covered population rather than the provided services that you as an ACO would provide that population. You know, and really that's it actually matches up well, I think, with the thought behind an ACO. An ACO is an arrangement where an organization is accountable for the population's care, and capitation is an arrangement where that organization is also accountable for the total medical cost of services delivered to that population. So from that point of view, there's at least a consistency of thought behind the structure of the organization and thought behind the payment structure that organization would be subject to. There are a few different types of capitation arrangements. I mean, there are service-specific capitation payments, which we'll get into a little bit later. But there's also partial capitation, which is really a fairly broad type of capitation, in that the ACO would take risk only for the range of services it can provide to its members, not necessarily all of the services that would be provided to that population. If there are some services that the ACO could not provide itself, if the ACO is a collection of physicians rather than a collection of physicians at hospitals, that might be a more limited capitation arrangement. If it's a relatively broad group of providers coming together to form the ACO, then it's a relatively broad partial capitation and acts more like full capitation. But really the key here is that a subset of services are subject to capitation, and the rest of the services are subject to fee-for-service arrangements or other types of reimbursement arrangements. And then full capitation is really what we generally think of as capitation when we talk to our clients, where the ACO or provider organization would take risk for all the services delivered to its members, whether that ACO provides those services or whether they get their care from other providers, either out of area or other providers within their area that are not part of the ACO. So really the key for capitation is really that the ACO will know what they do for a population, but they also need to consider what others will do for their population as well in building the capitation targets and understanding the range of services that are being paid. Next slide, please. Now, there are certain characteristics that we think an ACO has if it's going to be a financially favorable system for them to be paid under. Some of those characteristics are listed here on this slide. The first of which is that it's a highly integrated system. A highly integrated system has the structures in place for providers to work with each other, for physicians to work with hospitals and other and ancillary providers in order to better control the care management of the population, to really manage the person and not the service. Organizations that are highly integrated would do better under capitation because they have those care management skills. Also, effective care management initiatives, changes that are going to be made in the future, as well as making those care management initiatives consistent with the way that that an organization pays its providers internally. So not just that that the organization at a high level understands that it needs to become more efficient, it becomes more efficient, but also that it provides incentives for its own providers to assist in those initiatives, so that everyone in the organization's goals are aligned and are also aligned with the financial structure that the organization is using. Typically, what we see in developing capitation rates is that rate is related to the average efficiency level in the market that we're talking about. So if your provider organization or ACO is more efficient than the rest of the market, or if it's on a path to become more efficient than the rest of the market, then capitation probably makes more sense. Narrow networks, again, the more controlled the provider panel, generally the easier it is for that provider panel to manage care and to create the efficiencies that drive good financial performance under capitation. It also makes sense where possible for the ACO to work on a collaborative basis with payers, whether it's public payers or private payers, to coordinate efforts on cost control measures. Oftentimes, an ACO doesn't have access to the population-based data of all the services that a member may use. Perhaps their pharmacy records, or their out-of-area claims, or just out-of-network claims, and it's hard to manage a population with only a certain percentage of the data. So if there are opportunities for ACOs to work with payers, again, whether it's Medicare or whether it's a private insurer, to tap into that population-based data, that's also a great plus in being able to manage under a capitation arrangement. And then really, I mean, probably the biggest constraint over how well you do under capitation is that there has to be a fair and equitable method to actually set up the capitation rate. Next slide, please. Several keys to establishing reasonable capitation rates is really understanding your underlying efficiency level as an ACO and what that means to the capitation rate development, along with the referral patterns and cost of the other providers in the community that you will either be using as part of your network, or perhaps competing against, in that the capitation rate, like I said, is generally set at somewhere near a market average. So that if you are on the higher end of the efficiency scale in a market, and the other providers in your market that you'll be using to fulfill parts of the care management responsibilities for your population are at the other end of the spectrum, you have to understand that and know what that means to your financial viability under a capitated arrangement. You also have to precisely define the services that are included in the capitation rate. This is something that probably gets less attention than it really needs to, up front, you have to be very specific about what's covered under the capitation rate and what is not covered under the capitation rate, so that you understand the incentives that you're creating in your system, and also understand what risk you're taking on as an ACO. The target should be adjusted for the risk of the covered population. Again, it's probably something that really doesn't need to be said, but I think now we have more precise ways of actually measuring that risk on a prospective basis, not only by age and gender, which has been the classical way that you look at the projected cost of a population or different sectors of a population, but also now that there are many types of diagnostic-based and pharmacy-based risk adjusters that can predict the relative acuity or relative cost levels of different sectors of the population that you may enroll as an ACO compared to market averages. And it's critical that those types of risk adjustment processes are done under a capitated arrangement, under a shared savings arrangement, anything where you're being compared against a per member per month cost target. That cost target has to represent and reflect the underlying risk that you're taking on. Whether they're under Medicare, that's the existing Medicare risk adjusters that are used in Medicare Advantage, or whether it's a different risk adjuster, just something that really needs to be understood. In many capitated arrangements, there are administrative responsibilities that are under the purview of the ACO. There may be administrative responsibilities that either Medicare would take on or a private insurer would take on. Similar to the comment I made about having to understand which services are included in the capitation rate, which services are not, you also have to understand which administrative services that you as an ACO will provide and be able to budget and account for those. There has to be an equitable process for the annual rate updates. Often you're not just entering into a one-year deal. You have a multi-year deal with the expectation that the actual rate will be updated on an annual basis, so that it takes into account changes in the marketplace, as well as anticipated changes in the efficiency level of the services delivered under the contract. So that has to be looked at on a regular basis. And in order to facilitate that process, there has to be an accurate reporting process, so that all parties know how the financial ramifications of the deal are developing over time. You have to understand it on an external basis. There's reporting between the ACO and Medicare, the ACO and the insurer, to understand where things are going between those two parties, but also just internally as an ACO, you have to understand on a very regular basis, quarterly or monthly, how you're doing against the targets that have been established, either the cap rates or the shared savings targets that are out there, and be able to use that information with your own internal providers and internal management to help change behavior as you go through this process. Because it's not like turning a switch. You're not going to enter into a capitated arrangement or a risk-bearing arrangement, and from day one, have the information that you need to manage on a population basis. It's an evolving process, and there's a process of continuing improvement that you need to undertake, and really the biggest input in that is that population-based information that you can glean from both claims data as well as electronic medical records that you have as providers in an ACO. Next slide, please. So Keith mentioned this. I mean, the capitation world has been around for a while, and back in the 1990s, when it was probably most prominently used, there were a lot of provider organizations that went into capitated arrangements. There weren't a lot of provider organizations that were successful in those capitated arrangements. There were quite a lot of failures, arrangements that didn't work out for one reason or the other, but there were some successes. So that one thing that you have to look at as an organization, if you're one of the winners or one of the losers back in the 1990s, is what did you do then what are you doing right now, and how is that different, or how should it be different going forward? Some of the things that we see with our clients that have made changes since the 1990s, the world has become more integrated with electronic medical records, other internal systems that the provider organizations have, whether it's the use of homegrown clinical guidelines put out by other organizations. There's just a lot more information available and at the fingertips of both the individual providers and the leadership of organizations with which to make decisions about how services are delivered, and those decisions impact both the cost and quality of the services that are delivered to the population. So there's just a lot more information out there that's able to be used, and if used in the right way, can really increase the viability of these types of population-based payments. One thing that's coming out of the new healthcare reform law is that there are some provisions of the law that really provide incentives for payers to transition risk to providers in return for a more stable cost structure for themselves. Things like minimum medical loss ratios, where payers need to attain at least a certain minimum spending level on healthcare-related services. If they in turn capitate an ACO or other provider organization for those services at a constant per member per month level, that fixes a lot of their costs as an insurer and gives them a little more certainty on a year-to-year basis in that medical loss ratio calculation that will be done by each state's insurance department. Also, there's a lot more intense rate increase approval processes in states that that started last year in Massachusetts and have run through the country, with a lot of states that haven't collected a lot of information in the past are collecting a lot more information. So, and the more stable an insurer's cost profile is, the easier it is for that insurer to both move through the rate increase process as well as the minimum medical loss ratio process. So, so there is that difference from the 1990s, when really payers and providers were, didn't have any real outside pressure to come into these population-based or capitated arrangements. It was really just, in part, payers trying to offload risk to providers, whether they could really handle it or not. So I think that there's more willingness, I think, because of what's in it for the plans now, in order to work with the providers to understand if even they're ready for capitation. There are more refined risk adjustment methods that can be used now than in the 1990s that we talked about on the last slide. It's important to use them, understand them. And then, like I said, just the experience that you've gleaned from the past, or that you've gleaned from others' successes or failures, really should be used, as you plan through figuring out if you're ready for capitation now. Next slide, please. So Keith walked through a few different reimbursement methodologies: fee-for-service, bundled fee-for-service payments, medical home networks. I've talked some about capitation, and then there's really a whole host of different arrangements that are really a hybrid of all of those things. The goal, if there was one, is to maximize the benefits of all of these different types of reimbursement arrangements, while limiting the deficiencies of each of these reimbursement arrangements, to try to use these component parts to develop a reimbursement structure that makes more sense in total than it does if you would use any one of the pieces. I don't know if that goal has often been met. It seems to be more of a piecemeal arrangement of trying something here, trying something there, without really that overall goal in mind of what their whole reimbursement structure means for the healthcare system as a total. So that the goals are aligned between cost and quality and access to services. We've seen two types of hybrid reimbursement models. The first one is a mixed payment model, which is really what I was just talking about, where there's just kind of a mixed bag of different types of models that are used in one provider system. Also, you can throw incentive payments or risk-sharing payments into this category as well, since there's a base payment made either on a fee-for-service basis or other basis, and then some sort of incentive payment, whether it's a shared savings model or other type of targeted incentive payment made around that. Next slide, please. A little bit more about the mixed provider payment models. From my perspective, I think this has really been driven a lot more by payers than it has been by providers. Basically, payers looking at how they can reduce the cost of health care and looking at it in a little more targeted way. Certain providers may be paid by capitation while others paid in other manners. Kind of the classic system that we see a lot is that the primary care physicians are paid under a primary care capitation arrangement or medical home network arrangement. There may be some ancillary caps for high-cost radiology or DME or home health or something like that. And then everybody else is paid on a fee-for-service basis. And that system has kind of really grown up from payers trying to get the best reimbursement rates they can for different sectors of the population. But if you think about it, sometimes that that mixed model isn't as consistent as maybe it should be to maximize both cost savings and increase quality. This could be an effective structure for an ACO if the capitated part of the mixed provider payment model is the ACO itself, and the fee-for-service part of the mixed provider payment model would be the other providers providing care under for that population that's being managed by the ACO. Because then the providers that are part of the ACO all have the same incentives, and they are also ordered incentives not to use those providers outside of the network that would be paid under a fee-for-service model. So, in certain circumstances, these bifurcated models can make some sense. Next slide, please. If, however, if a part of the ACO is under a capitated arrangement and another part of the ACO is under a fee-for-service arrangement, depending on the impact of the care management initiatives that the ACO has in place, some of the providers may do well under their arrangement. Some of the providers may not do well, and there's winners and losers, and as an organization, you're not all rowing in the same direction. So there can be some difficulties and inefficiencies built in a system like that. And if only some of the population or some of the providers are capitated, there's limited incentive for the ACO as a whole to reduce the operating costs of those capitated providers, and that really just becomes a focus of the providers that are capitated. So again, it's not everyone's not rowing in the same direction and doing the same thing, so it's not as efficient as it could be. Next slide, please. One of the things that we've been sharing with some of our clients, and some clients have been developing, over the last year or so, are blended payment reimbursement methodologies that really do align the incentives of both the payer and the providers under the payer to have a system that really makes sense and for everyone and provides incentives for everyone to cooperate and reduce cost and increase quality. I don't think we have enough time really to get into the details of this particular blended payment reimbursement model, but in essence, each provider is paid for the same service both via capitation payments and fee-for-service payments to provide appropriate incentives around provider operating costs, so that essentially a certain level of a provider's fixed costs are covered by this arrangement, with other incentives provided for the variable piece of cost of providing services. If properly structured, it really does provide a strong alignment of incentives among the ACO members to improve efficiency. It leads to doing the right thing means a better financial result for everyone. So it also addresses many of the other deficiencies of a pure fee-for-service or pure capitation model. Again, it's just a few of our clients that are starting to use these types of models and are pretty excited about it. And I think you'll see some pretty creative things coming from some organizations. Next slide, please. Incentive programs can also kind of fall under this mixed or blended type model. I mean, they're typically used in combination with fee-for-service payments by health plans to address specific issues, whether it's quality incentives, incentives to provide access to services for a health plan's population, whether it's a shared savings arrangement that's kind of laid on top of the fee-for-service system. It's just arrangements that have specific incentives for specific outcomes. It can be an effective model for an ACO as it transitions from population-based payments, from fee-for-service or volume-based payments to population-based payments to first think about managing the population as an incentive payment, and gradually get to the level where where as an organization your total payment is based off of payments related to the population characteristics and not the characteristics of the services that you provide. Next slide, please. Some things to think about as an ACO transitions from where you are today to where you may want to be in the future, dictated by your own internal activities and just the changes in your market. Risk diversification is important during this transition. There aren't a lot of organizations who are going from fee-for-service and jumping directly into 100% full capitation. So as your contracts roll over with individual payers, they're usually multi-year contracts. If you want to head into a direction of being paid on a population basis rather than a volume basis, naturally that's going to occur over a period of years. And it's important to understand that, understand how the incentives change from day one to to year 5 or 6 when you're finally where you want to be long term. You have to promote efficiency consistency among the efficiency initiatives you have and the internal reimbursement models as well as payer reimbursement models, so that what the left hand's doing, the right hand understands and reacts to it. And really the managed population also should be sufficiently large enough, to make sense as you're moving to this population-based payment. The smaller the population, the more normal cost variability there is because there's less people and healthcare costs aren't known perfectly. There are a lot of random variation in healthcare costs, but as the population grows, the stability of those estimates and results increases quite a bit. You also have to have enough volume in order to produce meaningful experience data to help you manage. If you have 2 cases of this and 1 case of this and 3 cases of that, it's not going to help you understand how efficient you're becoming or how you're changing your care patterns. You have to have enough volume to understand where you were and where you're headed. And then also you just have to have enough volume for anyone to care about the initiative. I mean, there has to be enough skin in the game that the real work it's going to take to change behaviors is going to be worth it. You have to have a large enough population where it's it makes sense to make all the infrastructure and operational changes that you need to make. Next slide, please. So really, I think our presentation was really probably a little bit more general than just Medicare ACOs. But I think as an organization, what you do with Medicare ACOs really has to fit into the reimbursement model that you have in general. So it's important to understand. It's important to understand how these different pieces of your organization fit together and how they all have to work in concert in order to have an organization that's really structured so that what it does on the operational side is consistent with what it's doing on the reimbursement side. So thanks for your attention, and we'll look forward to your questions.
Thank you, John and Keith. We're now going to take a 10-minute break, and we'll see you back here in 10 minutes. Thank you. PricewaterhouseCoopers Indianapolis office, and Vicki Perry and Warren Skia.
Thank you. Well, it is certainly the title to this section suggests not only financial considerations, but really considering this a journey to better or improved health care. Certainly talking about the lessons learned and some of the discussion points of Franciscan Alliance ACO. But it really is a journey, and as the picture to the right suggests, is here's where it gets tricky. Clearly there's a number of things that you have to be cognizant of and aware to be successful as you set this up. And I think now's where we're going to roll up our sleeves a little bit and start talking about some of those interventions, how that may work, what are the cost structures, et cetera. And certainly Vicki's going to give you a really good flavor of that. Next slide, please. So, one of the phrases that we've heard an awful lot coming out of D.C. and attached to the concept of ACOs has been bending the cost curve. However, I think it's critical to understand that we're really thinking about bending, and I think it is the appropriate metaphor. We're not breaking that cost curve. Talking to some clients and physicians, I think the wrong interpretation of this is breaking that cost curve, because that's not at all the intention. Again, as we mentioned off the top, there is significant investment in infrastructure required, and in order to be successful for a long period of time and keep that cost curve bending, not just a little ripple effect, if you will, in that cost curve, it does require significant infrastructure. So we're not looking at taking the PMPM and cutting it in half necessarily, because in order to transition and transform a hospital organization to a true ACO healthcare organization does require significant infrastructure. So again, this graph really represents that shared savings and the shared savings model that CMS and the Dartmouth-Brookings Collaborative has talked about for some point of time or period of time here. I think what we want to avoid is, again, the impression and the understanding that there is a significant break in that cost curve, because indeed that's not the case. At this point, I'm going to turn it over to Vicki to tell us a bit more about that.
Thank you, Warren. I'm very excited about having the opportunity to talk about something that's very near and dear to my heart. What the title was supposed to be more finance, and what I'm really going to talk about is investment. And I think it's absolutely critical that we fully understand where we are as a health system, where we're going as a health system. Next slide, please. This is really a true evolution kind of picture more than anything. And you'll see that I use a lot of pictures instead of words here. Bottom left is, the bottom axis really talks about the level of integration, with the left being very low integration, to the right being a highly integrated delivery system model, physician and hospital and ancillary integration. The top really talks about the levels of economic change, with the far left being kind of the traditional fee-for-service. You may have some P4P initiatives going on, and then all the way to the far right, where the last speaker really talked about different capitated health system models to drive risk within the organization down. I like to think of the far right economic side really being the true integration and alignment of goals, objectives, resources, and that's where the true investment comes in. On the left, the current fee-for-service model kind of leads into the kind of the lime green, and that's because it is still on the very low physician-hospital integration dependence. Moving down by type of healthcare model, you've got your IPAs that are very integrated as a physician group, but they're still very dependent on fee-for-service. So as they begin to integrate into either physician-hospital organizations or ultimately kind of the true ACO model, which is the true integrated delivery system model, you'll see that they start moving over to the far right in the partial to full capitation model. I think it's important to understand, again, where you are on this kind of continuum when you start thinking and really positioning yourself to be an entity that is involved at some level of an accountable care organization. What does an accountable care organization specifically look like? I'll show you on the next slide, please. This is a schema that is a likely model of partnership and collaboration and contracting. If you're dealing with a large regional area that may have multiple health systems that want to share infrastructure for a lot of reasons, not the least being just the cost of capital impingement on a particular health system, and if they can share because of the regional logistics being supportive of that, it's a better potential financial investment for them. You have in the middle of the dark blue is a joint venture or some type of new code that really becomes kind of the infrastructure for the governance. That entity is likely to then contract with multiple health systems within the region and other types of physician integrated models, such as physician hospital organizations or multi-specialty groups, or even physician practices, individual or physician group practices that are on the primary delivery system side. On the far right are support, what I like to say, support providers that are true strategic players within the continuum of care, but may not, for purposes of risk share and or governance, really be an entity that is part of that new co or that joint venture from an ownership perspective. And then, of course, you need the infrastructure. We're going to talk a lot, I think, about the different components of an infrastructure, but in this type of model, as the last speaker talked about, health plans are ahead of an accountable care organization or an integrated delivery system model when it comes to understanding the insurance components of an ACO. Contracting services, financing and payment support, whether you're on a capitated or partial capitated or global or bundled payments, you need a means of managing that economic exchange of funds. Data integration. Most health plans that are going to get into the ACO model probably have a fairly robust data management information system already in place, even to the extent that it may be very supported by or supported very robustly by a repository, which pulls in claims, but also can integrate different types of encounter data. Systems are used to doing this for Medicaid and to some extent even some of the SNP Medicare options. So that's a very expensive, very complex process that health plans can bring to an infrastructure very early in the development game. And then also, I think the other area that health plans may have a leg up, so to speak, in the infrastructure and support for an ACO is the true population management. For whatever reason, particularly regional health plans or provider-owned health plans are very focused today because the margins are very low in really trying to identify where can you put your resources to get the biggest bang for your buck, so to speak. And that is in truly managing the population, not managing necessarily encounters or prior authorization of services. It's really identifying where's the risk within the population and how can we devote the appropriate resources at the right time to change the outcomes and improve the overall quality of care provided as well as the overall quality of health of that population. I also want to, next slide please, really show the type of model that we have in place or that we are very far down the kind of the transformation with the Franciscan Alliance Accountable Care Organization. And I know that earlier today you had Warren and Jay on first, I believe, and they talked a lot about this, so I'm not going to spend a lot of time, but again, I think that this really takes the, the likely schema that we just reviewed into real practice. And as you can see on the far left, St. Francis has a number of Franciscan affiliated collaborative partners, and bringing them all together really provides a much more robust opportunity for early success. They've also gone through an internal assessment to say, okay, we own a health plan, where, rather than duplicating or replicating, where can we really collaborate on resources, skills, best practices to drive those outcomes as early in the process as possible. They also have spent a significant amount of time really looking outside of the hospital walls to really identify the collaborative or other strategic partners that can bring value in the overall population continuum of care. The ultimate goal of the Franciscan Alliance is not just to transform a delivery model, because they're very far down that continuum today, but it really is to transform the community itself and how the expectations for better value in healthcare, better value for the healthcare dollar, really can be realized. Next slide, please. So if you're sitting there as part of a physician hospital organization or some kind of provider organization, you're probably saying, well, isn't just the accountable care organization another name for what we're doing? And it really isn't. It's a cultural shift as much as a procedural and process shift. On the left are kind of it's the expectations today in most of the markets that we all serve or should be serving, and it's how those perspectives are really going to change into attributes that really reward value. On the left today, everything's charge-based. There really is an incentive to perform services irrespective of the quality and or the recognition that it's the right thing at the right time. In the new model, it's going to be very physician-directed. It's going to be very patient-directed. It's going to be very collaborative. Consumers are going to buy based on quality, not just based on cost. Cost may still be a factor, particularly in the next 3 to 5 years, but ultimately, if you're really focusing your accountable care organization's efforts into changing the delivery system model through a continuum of care, you're really going to be impacting the length of services. You're going to be impacting where services are provided. You're going to have physicians really change. The real investment here is going to be on, what are you doing to impact the life, the health, and the cost of the patients that are being served through that accountable care organization. And that kind of plays into the next slide, please. And this is the triple aim. Triple aim is not a new concept, but it's a concept that is being talked a lot about at CMS. Departments are talking a lot about the triple aim. And what it is it's transforming a model of care to do 3 things. There are 3 targets. It's to improve cost, drive efficiency throughout the delivery system, and to improve the patient experience. On the left are the goals of triple aim, and on the right are initiatives or investments that you really need to have in place to be able to hit these goals. And I can tell you that virtually every discernment and change process that is occurring within a delivery system, if it's not going to impact one of these 3 goals, it's probably not worth the time and the resource to take that action on. Improving costs is about population management, and it's about population management across the full continuum. It's when you identify an individual that is a new type 2 diabetic and making sure that they don't enter the hospital through an emergency room because they're poorly managed. It's making sure that they understand what their responsibility is in controlling their diabetes. It's identifying gaps in care through very robust analytics and use of information that is gleaned through something as simple as a health risk assessment to a very robust integrated pharmacy and medical repository system. It's looking at provider experience through evidence-based medicine and metrics and really aggregating that clinical information and pushing it back to them so it does have meaningful use when they are either care planning or actually providing care. And it's focusing on the quality. What is the quality outcome, not the quantity of service? And that's where you're going to get some improvement on cost and, as Warren said earlier, bending that curve. To drive efficiency, it's all about data. It's all about your information systems and the integration of that. Everything from disease registries to being able to adapt to a system that isn't looking from a revenue cycle perspective to a fee-for-service payment, but is really looking at the cost of services provided under a global payment or a capitation payment. It is dependent on system-wide connectivity, and that's, when I say system-wide, it's the primary care office to the hospital to a handoff to a post-acute facility. And then lastly is improving the patient experience. And that is a physician, patient-centric opportunity. If the physicians are engaged and they understand the value of true primary care and the value of touching those individuals outside of the physician office through health coaching, different models of care, the primary care medical home, different point of service sites that may be after hours, ambulatory surgery centers, anywhere where you can touch that patient, make sure that they understand what their responsibilities are, what their triggers are, how to get services at the right time in the right place, and then ultimately making sure that they understand the value of the health care that they're currently getting. Next slide, please. This is probably my favorite slide and one that I could spend the next 2 hours on, but I obviously don't have that much time. These are interventions that are in place today in our health plan and in our Franciscan delivery system, their network. These are real cost analysis and assumptions and projected savings that we are building into our ACO as a means of really measuring our effectiveness of care and our effectiveness of the transformation of the delivery system. I do want to apologize because I know this slide so well, I didn't look at it real carefully, and the savings per year, those figures actually were repeated all the way down the slide, and I'm going to give you the real dollar value on that. Diabetes through health coaching, early identification, early intervention, has a cost for resource allocation of about $80,000 on an annual basis. And we are expecting that the savings per year, by keeping them, keeping the services ambulatory in the physician office and out of the emergency room in the hospital, and avoiding complications to poorly managed diabetes, on a 10,000 life basis would have a savings of about $615,000. CHF, if that's the primary, in each one of these interventions is the primary intervention only. We're not cross-counting or double-counting potential savings. But CHF has a, again, this is across the model of 10,000 lives. It has an annual savings of about $428,000. And again, it's using health coaching, early identification, helping them maintain themselves, understand how to manage the chronic disease process, keeping them active, and making sure that they are doing their physician visits at the right place at the right time. That has about an $80,000 investment, and again, it's about a $428,000 savings. Complex case management and transitional care, I'm going to talk about those real quickly. Those are services that are typically provided to the last 5 to 8%, or the highest 5 to 8% acuity or risk of a population of 10,000 lives. It is very resource intensive, it's very nurse practitioner and very coordinated and collaborative across multiple opportunities for intervention. Again, it's a very collaborative process and one that has the greatest opportunity for avoiding unnecessary utilization and unnecessary services. Complex case management for 10,000 lives will save about $920,000 per year, and transitional care, making sure that individuals that do have an acute event get home or get to the lower level of care safely, have the resources, understand their triggers, are medication compliant, and stay at that lowest level of care with a good quality of life. That has about a $1.3 million per year savings opportunity. And those are very, very conservative savings, and they're based on interventions that are in place today on the Advantage Medicare lives, of which we have about 7,000 today. So these are real, this is where you need to put your resource to really impact the reward and the opportunity for improving the quality of care. Next slide, please. So probably not having a good feel for how many in the audience really are ACO energized versus consultant energized for ACOs. I'm going to just kind of throw this out there quickly. This is a process that we have actually gone through, and it's really transformed our delivery system from a very kind of commodity type focus. We've never been fee for service, but the market has always been fee for service. We are a smaller regional health plan. Market is dominated by Anthem WellPoint, but we are making significant strides in really moving the market expectations to understand that the fee for service is a commodity, and the fee for value is the next opportunity within the market. We are really focusing on educating the legislature, educating the employers, educating the providers, having alignment and a lot of engagement at those levels, really across all the stakeholders. And it's all being focused on not who has the cheapest or the broadest network, but who's avoiding the claims cost. How are we impacting the population to really make sure that we don't have unnecessary utilization or unnecessary readmissions to the hospital. And this is where the collaborative opportunities between hospital, provider, and health plan or ACO really can come together and drive the results in a very rapid, robust way. Next slide, please. This is really, once you decided that you're going to move through that continuum up to the far right where you're providing the best value, these are really 3 steps and 3 very integrated kind of discernment and investment opportunities. In order to really do population management that impacts long-term the health of the community and certainly the ACO population, there's necessary tools. It has to be a very patient-centric, primary care-driven model. That is not a model that typically exists today in the fee-for-service traditional PPO world. You have to have an integrated clinical information system that drives meaningful use of the data and the information that is available across the continuum of care. And almost at the top of the list is physician engagement. Without the physicians, the health plan, the hospital, the patients can't do it. So early engagement and identifying the early physician champions that are not threatened by primary care, but really buy into a primary care given model are critical to kind of moving to the next kind of transformation level. And that's where you begin to be able to adapt to payment changes. Population health management is certainly a great opportunity for the ACO to share in those savings. Shared savings is the CMS preferred model, but it's probably not the robust model, and it's not going to give you the early investment dollars to help drive the transformation of the delivery system. So looking at things like bundled payments and anything from modified to full risk, where you are keeping, as a health system and as a physician, keeping some of the savings that are being generated early to reinvest back into the transformation process itself. And then lastly, and this is kind of the last, I think that's when you've arrived, so to speak. This is when the journey is not over, but certainly changes the direction. And that's when the delivery system model does have primary care medical homes or patient-centric homes. You're really focusing resource on home care management, keeping them out of post-acute and or ER and hospital, and then true provider integration, so that continuum of care and the care planning and the population focus is at that physician-patient level. Next slide, please. And then once you've done those actions and you actually have transformed the culture and integrated the providers and integrated and identified best practices, you're really going to be ready for what I think is market evolution, irrespective of the CMS efforts, or really even irrespective of healthcare reform. There is a movement for, in the large, right now it's the large group sector, to stop paying for fee-for-service type models of care and to move into value-based insurance design. And if you can, in fact, integrate into an accountable care type organization with the right culture and the right focus, you're going to be primed to have market share that you may not necessarily be able to drive and keep driven into your ACO or your structure of model of care. And this is an opportunity to really, not just from an economic shift, but from a true community-wide expectation shift from a low-quality, high-quantity effort into a true value that puts the rewards, shares the risk, and really rewards the patients even, or the members of the ACO to do the right thing. It is, as I've said before, very, very provider and patient-centric, and it's very highly intensive and very dependent on good integrated delivery. So I think if we continue to focus on investing on infrastructure through integrated systems of care, best practices, physician engagement, and most of all, the high integrated technology, you're going to get there. You're going to get there very, very quickly. Next slide, please. And I'm now going to hand it back over to the one that could really talk about the finance side, Warren.
Well, thank you, Vicki. Clearly, as Vicki has outlined, you think of all the interventions and the opportunities to save dollars and resources spent on beneficiaries or attributed patients in an ACO is critical. And understanding that impact, and as Vicki walked us through that, clearly what you want to do is model that financially and what's going to happen. What you don't want to have happen is certainly on that top graph here. The bottom line, the dark line, is the projected spend that you negotiate with your payer, whether it's CMS or commercial or otherwise. What you don't want to do is see that you haven't achieved that. You've, in fact, overspent, if you will, and exceeded that projected spend line. In a symmetric model, then you will be thinking, I've got to be responsible for some of that overspend and pay back my payer, if you will. I'm at risk, if you will. That's obviously what you want to avoid. Clearly, it's where you want to be is in that bottom graph, again, below that. So what you're going to do is model out all of those interventions, as Vicki aligned there and talked about, including complex case management, transitional care, CHF, transitional care, et cetera, and say what kind of impact is that going to have across time, and then hopefully, again, you've got that actual cost savings, and wherein you get into that shared savings approach to ACOs, where in fact you can actually garner some of those savings back through the negotiated contract you have with your payers. Next slide, please. So, putting this all together in terms of, kind of the financial model, if you will, philosophically. And again, this is just an example. Some of the things we've talked about, again, not based on a real negotiated ACO per se at this point. But if you look again at that that middle line, if you will, being the spending benchmark, that is in terms of where you anticipate the spend to be, again, bending that cost curve. The solid line above it is, again, a potential overspend. Hopefully we don't get there. Below it is in a cost savings situation here, and hopefully that's the place where we want to be with all of our interventions at the end of the day. So let's just take the overspend as an example. What you want to do is say, what's your risk model? What are you at risk for? And in this instance, we just modeled out, for example, if it was the Franciscan Alliance ACO taking on a 50-50 risk with CMS or any other payer, you would share that risk over and above that negotiated spending benchmark, usually on a PM basis. At the same time, and where it's, there's still, I think, waiting for some clarity, if you will, from the regs by CMS and negotiated with other payers is, what happens if you get below that and get into a shared savings situation? What's going to happen? And, different examples of this, again, you split it on an 80-20 basis. That is the ACO taking on 80% of those shared savings, 20% back to that payer. I know there's CMS, there's been some discussions last year at some of the national ACO workshops and et cetera in DC, but I don't think there's any final ruling on that. I think most healthcare providers certainly feel, though, if there's risk on the overspend and they're taking on some of that financial risk there, that indeed there should be, the reward should be that they get a bigger portion of the savings. So it's, again, that risk-reward principle, again, that you need to model out and determine what your threshold is, as a healthcare organization. So, Vicki?
Just one thing. I think it's also important, when you're either negotiating with CMS or another payer, as you develop your ACO, there is a lot of investment there, as I've said, and the more that the savings can drive that investment further, the higher that savings opportunity may be. So I think that's a very logical position for the ACO to take.
Yeah, no, that's a great point, and certainly, that's why when we started out this section about bending the cost curve as opposed to breaking it, because obviously, some of that is the low-hanging fruit in those first couple of years, perhaps, of interventions in order to get those savings, but in order to avoid getting right back on that same spend slope, if you will, of spending, that investment has to occur in that infrastructure, to Vicki's point. So the next slide, if you will, really kind of talks a bit about if you took that negotiated approach that we just described in this particular slide, that you would want to model that out. We've taken it, rolled up the PM and put on an annual basis. So again, you have to assume here that the quality metrics are going to be met in order to be eligible for the shared savings, and certainly that is a requirement that I think is almost a certainty. So what we've done is just, again, I'm not going to walk through these numbers here, but just by way of illustration, what happens if you're above and below that negotiated spend line? What does that mean? You need to think about what those potential shared savings are, what that overage is, if you will, in those different columns, and then ultimately, how much goes back to CMS, because of course they're going to want to know that as well, and then, the final cost for attributed enrollees into the ACO. So again, you want to be able to separate all those components, given different scenarios, and set up a model that you can financially model that, very quickly at a drop of a hat, so to speak. Next slide, please. So again, when you think about this journey, if you will, and it really is a journey at the financial model, certainly you have to make some assumptions. You have to decide look at your actual data to say, what kind of impact can I have? That's going to be different in every market. Again, that low-hanging fruit, but certainly you must recognize that there is significant infrastructure investment, and I think we can't stress that enough. And really there is a paradigm shift. There is a fracture in the delivery model from the current provider-centric reimbursement model, very reactive, to very much more patient-centered and accountable. All of the issues and all the things that we're trying to solve and goals and objectives of an ACO are critical, and it's going to take a significant amount of modeling and tactical approach to how that can get done. And all along, you're going to have to model that very carefully financially, and certainly we would recommend having a very robust model in place in order to do that. Next slide. Thank you.
I think that's it. Thank you very much for the opportunity.
Thank you very much, Warren and Vicki. That was very interesting. We're now going to go to a presentation entitled "These Were the Good Old Days, First Steps Toward Health Plan, Health System, ACO Collaboration." And we're going to go first to Alan Hoops out in Los Angeles.
My apologies. It caught me a little off guard there. I didn't think I was up yet. Thank you. It's nice to be here. I'm Alan Hoops, chairman of CareMore, and let me start with some basic introductions. Let's go to the next slide, please. By way of basic introduction, CareMore is a Medicare Advantage plan. We have 55,000 members, and we do business in California, Arizona, and Nevada. I think, although we're a small player, I think in the last 5 years we would feel pretty safe in saying we've been a relatively successful Medicare Advantage player. Since 2006, we've grown our membership from about 19,000 to almost 55,000. We have opened in 7 new cities in a time when very few Medicare Advantage plans were starting in new markets in a de novo fashion. And I think it's safe to say that we've probably been one of the more profitable plans in the country during that time as well. We think, however, that our success as a Medicare Advantage plan can be directly attributed to a proprietary model of care that has been developed within CareMore. Now, in some regards, we resemble a fairly traditional plan in that we contract with hundreds of physicians, PCPs, and specialists in the marketplace, as well as the community hospitals, of course. But supplementing and, in some cases, supplanting that community-based network is a core system that is proprietary to CareMore. That core system is rather unique in that it focuses on the minority of patients who consume the majority of costs. Generally, that subset of patients is made up of the chronically ill, frail, and end of life. Can we go to the next slide, please? We often describe CareMore as a care model in a Medicare Advantage wrapper. Before health care reform, virtually all of our development work was with other health plans, talking about how we could integrate our model into their networks and their benefit packages. Post-health care reform, however, virtually all of our discussions, rather than being with health plans, are with health systems, hospital systems. And we're discussing how our model can be used as a platform that will help those health systems become ACOs. And let me be clear, I haven't heard all the presentations, but when I say ACO, it really is a euphemism for building an organization that's capable of taking risk, regardless of where the risk comes from. Commercial carriers, Medicare carriers, Medicaid, et cetera. This slide talks about the goals that we discuss with health systems as we, in the conversations we're having. And I'll just go over them briefly. One is to be able to allow the system to manage population and episodic risk, all risk, not just population risk, but DRGs, bundled payments, et cetera. To help the system aggregate physicians, provide a value proposition that will encourage physicians to affiliate and show affinity for the system. To create proprietary products and gain market share. It's one thing to be able to prepare yourself to take risk. It's another thing to turn that risk-taking into products that will go out and actually win in the marketplace. Prepare to be an ACO and prepare for exchanges. This is more healthcare reform focused. And finally, the broad objective is to gain market share, actually win in the marketplace. Next slide. The purpose of this slide is largely illustrative. It states the obvious, what probably most of us listening know, that 15% of the population, and by the way, this is Medicare data, 15% of the population spends 75% of the money. The practical implications on this, that this slide has and this information on setting up an ACO is significant. What's implied here, but not ever stated, is that for 75 to 80% of the population, the current system works pretty well. The common wisdom and rhetoric in the marketplace, and frankly, the attitude with which systems come to us is the system is broken and it needs to be changed. And we agree with that. But I think our agreement would be highly concentrated and practically limited to that end of the curve that represents that 15% of the people and 75% of the money. Rather than try to change everything, let's change something that goes where the problem is. CareMore system attacks the problems of the most costly subset of the population. And I think one of the byproducts is that we kind of leave the rest of the system alone. And then one of the byproducts is that the rest of the system performs better for the 75 or 80% of the population for whom it was really designed. The model really has three critical success factors. We believe that operating successfully in this kind of a paradigm, you have to do three things well. You have to manage the complete acute care episode. And I'm not just talking about the time when the patient is in the hospital. To the extent possible, getting involved before they're admitted, and certainly providing all of the post-discharge follow-up and work. Second critical success factor is managing chronic disease. 5 chronic diseases account for almost 75% of Medicare costs. By definition, they're not curable. They're manageable. They take an absolute control over a long period of time. If you do that successfully, you will be a winner in this space. And the third thing is, to the extent possible, be as good as you can in predictive modeling. Predictive modeling is as much an art as a science, but there is some value in predictive modeling. And being able to tell when a patient is at that inflection point and is going to move from a relatively stable person to one who is vulnerable to highly increased costs. Being good at predictive modeling, however, is only half the story. You have to have the resources to intervene and intervene quickly. And the CareMore model has a lot of services that are designed to do just that and be deployed quickly. Next slide, please. As I mentioned earlier, in addition to our contracted network, the proprietary system that CareMore has focuses on the most costly population. This slide provides a very high-level description of the fundamental components of that model. The first is a CareMore extensivist, and this is an employed physician employed by the health plan whose principal role is to manage the acute care episode. So in many respects, they are a hospitalist. But their job doesn't end at discharge. They follow the patient post-discharge, and in the case of a very elderly, very frail person, they may actually follow and coordinate that person's care for the rest of their life. So that acute care episode is defined by us, and it ends when we say it ends. The second component is the CareMore Care Center. We have 30 of them in the markets that we operate in. They are not physician offices. They're not urgent care offices. They are venues in which our chronically ill and frail are provided with services. They are where most of our disease management programs take place. And in many regards, they serve as a touchstone and a point of security for the very frail and chronically ill. The third component is a highly empowered group of case managers. That's powered, but I meant empowered group of case managers. And their job is, they work closely with our extensivists, of course, but their job is really to ensure patient compliance with our disease management programs. And they have at their beck and call a constellation of services that are designed to get care where the patient lives. Disease management in the last few years has kind of gotten a bit of a bad rap because it has not delivered on some of its promises. But I think when you really review the data, disease management works. What hasn't been able to be achieved is patient compliance. CareMore assumes the responsibility for patient compliance. If we have to go to a patient's home, we will. If we have to provide them with transportation to the care center, we will. But all of those things are within the purview of the case manager. Next slide, please. This point, I may take issue with the previous group. Not issue, but I would say our program contrasts a little bit. We kind of break the cost curve in many ways. Obviously, saving money is a huge goal, but providing better care is what we're in this business to do. ESRD, nursing home patients, CHF, and diabetes are just examples of categories of patients that drive that 15% of the population to spend 75% of the money. There's been a lot of rhetoric about bending the cost curve, and usually they talk about reducing the rate of increase, and it's usually a goal measured in low single-digit numbers. We've demonstrated that if you focus on that 15% of the people, that you can have dramatically lower costs in the neighborhood of 25 to 50%. For CareMore, we saw that ESRD patients, when they got sick, went to their dialysis center. The dialysis center sent them to the ER admitted them. We intervened with primary care at the point of the dialysis center, and within months, reduced hospitalization rates by 50%. We see all of our institutional patients once a week, and we virtually eliminated pressure wounds associated with people in nursing homes. CHF patients, we put remote monitoring in their homes to measure their weight. If they gain weight, and we read those weights every day. If they gain weight overnight, we send a car, pick them up, bring them to the care center, intervene, and within months we were able to reduce hospitalization rates by 50%. Diabetic amputations, we trained a group of NPs in in wound management, and we manage wounds very aggressively. Wounds at CareMore heal in 1/7 the time that Medicare in general, and as a result, we've been able to reduce amputations compared to Medicare statistics by 60%. Next slide, please. So in talking with health systems about partnering with them for ACOs, we think we bring a couple of very unique value propositions to key constituents, meaning the primary care physician and the hospital. By taking the most complex patients off the backs of PCPs and sharing the cost savings with them, Caremore has been able to increase the per-visit income for physicians, importantly, free capacity in their practices, and improve their professional lifestyle. With regard to hospitals, by managing and coordinating resources consumed as an inpatient, we've been able to lower length of stay, lower readmissions, and importantly, lower the cost per day of the hospital. We have a relationship with the hospital in which we've been able to demonstrate $300 to $500 per day in cost reductions. We have a goal of being able to virtually guarantee hospitals that we do business with that they will make money on our per diems. And if we're given enough involvement in the cost per day, we think we can deliver on that promise. Next slide. I assume it's up there. We can't see from here. The last slide is really just a broad summary of the guiding principles that we include in our discussions with health systems about ACOs. Above all is probably the creation of really completely aligned incentives. If the business goal is to seek out and manage risk, both parties have to win or lose together. We've also included in some of our discussions, actually most of our discussions, the possibility of actually a jointly owned Medicare Advantage plan. This is not necessarily a prerequisite or a critical component of being an ACO partner, but what we found is that it's very attractive to many of the people that we are talking to. But the ultimate goal is to create a management platform that will allow that health system to seek out and manage risk effectively, gain market share and profitability by managing risk from whatever source. So the ultimate goal is to build a platform that is basically payer agnostic. And I guess in one closing statement, I would say that having aggressive